Afternoon. Welcome to session 55, Andrological Predictors of Healthy Pregnancies with Live Births. We have the pleasure to have two outstanding speakers, and it's my pleasure to introduce Professor Francesco Lotti. Professor Lotti is from the University of Florence, Andrology and Gender Endocrinology Unit in Italy, and he's also from ESHRE, is the Special Interest Group Andrology Coordinator. So welcome, Francesco. The floor is yours.
So thank you very much for your kind presentation. Dear colleagues, dear moderators, these are my academic positions, and they declare no conflicts of interest. And as you saw, this is the title, so it is Clinical and Ultrasound Andrological Parameters Predictive for a Pregnancy with a Live Birth. Infertility is a global health issue, and all of you know that about 15% of couples of reproductive age are affected by this infertility, and a male factor is present in about 50% of cases. We have several information and clinical thresholds suggesting male infertility. Regarding medical history, think about the history of cryptorchidism or previous chemotherapy for a male. Seminal parameters, we are used to say that when the parameters are below the 5th centile of the distribution of the WHO manual, there can be a higher prevalence of male fertility problem. There are hormonal parameters suggesting impaired testicular function, like high FSH, low total or calculated free testosterone, and clinical parameters such as mean testis volume reduced and bilateral absence of vas deferens that is certainly associated with obstructive azoospermia. But we also have some ultrasound thresholds of male fertility that could be considered suggestive of male infertility. I here show you the web page of the European Academy of Andrology multicenter study standardization of the male genital tract ultrasound parameters in healthy fertile men. This was a very important study that I coordinated with Professor Maggi in my center, including 11 EAA centers over Europe, and we could enroll almost 250 partners of pregnant women or men with a child less than 1 year, obtained through natural conception without systemic diseases and or medications affecting fertility. So they were defined as healthy fertile men. You can find information about study design and standard operating procedures of the study. This study led to some publications reporting evidence-based ultrasound reference ranges of the male genital tract organs in healthy fertile men, so to be considered as normal parameters. And according to this, what is abnormal could suggest male infertility. So this means that if we have a value of the testis volume below the lower limit of the reference range, for example, below 12 milliliter, this could be considered abnormal, and it is testicular hypertrophy. If we have some values of the epididymis or of the seminal vesicles that are above the upper limit of the normal range, it could be considered abnormal and suggesting dilatation of the epididymis and of the seminal vesicles, and maybe suggesting distal obstruction. However, they are thresholds suggesting but not predicting male infertility. In fact, we know that about seminal parameters, according to WHO manual, there are no sharp limits that can be used to delineate fertile or subfertile men. And if we consider the American Urology Associations, but even other scientific societies, and even publications on this topic, you can see that they report that semen parameter values falling above or below the lower limit do not by themselves predict either fertility or infertility. We have some seminal abnormalities that are certainly associated with male infertility. They are azoospermia, complete astenospermia, complete globospermia, necrospermia. However, with the exceptions of these parameters, none of the individual semen parameters is highly predictive for fertility or infertility. And I have some considerations. If you look at the previous publications on the topic, you can find that there is overlap between male fertile and infertile male. So the first study is a Danish study evaluating 430 couples, and they reported that a substantial portion of men can achieve a natural pregnancy despite their semen parameters being below the WHO reference ranges. In another study, it was found on the New England Journal of Medicine that there was a significant overlap between semen parameters of infertile and fertile men. And another one reported that in unselected couples seeking fertility treatment, semen parameters above or below cutoffs had no significant influence on the rate of conception. So we have to think about this. And we also have to think about other considerations. For example, there was this study by Silber. They found that in analysis of semen parameters of fertile men who achieved pregnancy and were seeking for vasectomy, about 25% of men had oligospermia according to WHO criteria, and 11% of men showed the sperm concentration below 10 millions per milliliter. And another point is more endocrinological. Think about men with Kallmann syndrome, so congenital hypogonadotropic hypogonadism. Under gonadotropic treatment, almost all men could get a pregnancy with sperm concentration below 20 millions per milliliter, and 16% of men in this study got a pregnancy with sperm concentration below 1 million per milliliter. So these are facts. And so it means that it's very difficult to use only semen parameters to predict male fertility. What about thresholds suggesting male fertility? We have a few studies, and in these studies, the outcome for fertility is mainly considered as inducing pregnancy. So I show you the data of the previous study I showed you on the 430 couples looking for pregnancy, the Danish study, and they found that sperm concentration above 40 millions per milliliter and a trend in the percentage of normal morphology were associated independently with the probability of conceiving naturally within 6 months. If we go on, there was another study that was published in the New England Journal of Medicine that reported that a concentration above 48 millions per milliliter, motility more than 63%, and morphology more than 12% could be predictive for fertility and were typical of fertile men. What about hormonal parameters? In this study, it was reported how was the distribution of FSH levels in fertile and idiopathic infertile men. As you can see, the FSH upper limit in fertile men is about 8 units per liter, and after evaluating ROC curves, FSH was predictive for proven fertility when it was lower than about 7 units per liter. According to this data, for example, in Italy, we have a regulation to use FSH treatment in idiopathic infertility when FSH is below unit per liter. In other countries and in other studies, another cutoff that is 12 has been used. We have other parameters suggesting male fertility. There was a fashion about sperm DNA fragmentation. You know that we have several tools and several ways to investigate it, but if we consider, for example, tunnel test that has a very good area under the curve for predicting fertility, usually the cutoff of 20% is used. And then there are some other potential markers and predictors suggesting male fertility, but still under evaluation, and they need several more data about the total antioxidant status, about sperm mRNA, about DNA methylation. Anyway, I would like to show you something new. So, what could be thresholds predictive for a pregnancy with a live birth? And after the previous consideration, I would like to show you some new data coming from a manuscript in preparation about the clinical and ultrasound andrological parameters predictive for pregnancy with a live birth, where we tried to identify in a comprehensive way seminal, clinical, biochemical, and ultrasound predictors of a pregnancy with a live birth, evaluated several parameters in males of couples that were infertile, according to WHO definition, and fertile with a live birth. And so we evaluated 115 healthy fertile men with a live birth with an age below 1 year, and they were enrolled by the Florence Center as a spin-off of the European Academy of Andrology ultrasound study, and followed up until they had a live birth between 2016 and 2019. And we also considered in our database 604 consecutive males of infertile couples. And we evaluated all these subjects with standard operating procedures, and within the same morning to have a photo of that subject during that day. Each subject underwent medical history, physical examination, seminal analysis, hormonal and glycolipid parameters, scrotal and transrectal ultrasound before and after ejaculation to evaluate the contraction of the seminal vesicles and the contribution to the semen volume, and validated the uro-andrological and psychological questionnaires. So the methods are these. They are a bit complicated, but first we have a comparison of the clinical characteristics of the two groups, males of infertile couples and males of fertile couples with a live birth. And then we had iterative curve logs to identify continuous parameters and related thresholds predicting a pregnancy with live birth. And using the thresholds as a dichotomic variable, we had a binary logistic regression to evaluate the probability or risk adjusted for confounders, so the odds ratio of those thresholds, and of dichotomic parameters such as, for example, homogeneity or inhomogeneity of the testes, to have a pregnancy with live birth. So these are the results. If we compare the socio-demographic and gynecological characteristics, we can see that there is no age difference of males and female partners. There was a higher, as expected, a higher prevalence of gynecological problems in infertile couples and low gynecological problems in female infertile couples. And when we evaluated the comparison of the groups, as expected, males of fertile couples had less abnormalities at physical examination, better seminal, hormonal, ultrasound, parameters, scores at urological and psychological questionnaires. But what is very interesting is the ROC use and then the odds ratio. These are examples of identification of parameters predicting the pregnancy with live birth. So examples of some ROC use, but we had ROC use for all the parameters evaluated. And you can see, for example, that we could identify with ROC use sperm concentration above 40 millions per milliliter was predicting pregnancy with live birth. FSH below 3.8 was a more accurate value to predict the pregnancy with live birth. And another example, particular volume at ultrasound with ESHRE formula, more than 16.5 milliliter was the best predictor of this. After that, using these ratios, we could have the odds ratio adjusted for age and male partner age, related to different parameters for pregnancy with live birth. And what you can see is that sperm concentration about 40 million per milliliter, total count above 128 millions, and sperm motility, progressive sperm motility above 52% were the best predictors for a pregnancy like live birth, but also normal sperm morphology, while semen volume was not. If you look at the hormonal parameters, you can see that different hormonal parameters are predictive anyway with a lower odds ratio compared to seminal parameters. So it means that seminal parameters are better predictors. And if you see to the medical history, female partner age below 35 years old, and the absence of history of cryptorchidism were good predictors. Anyway, as expected, even the absence of sexual dysfunction, the absence of psychopathology, so less burden, but also at physical examination, mean testis volume above 20 milliliters and absence of dilatation of the epididymis. But what is more important, and it was really incredible for us, was that the parameter among all the parameter studies that showed the highest odds ratio for predicting the pregnancy with a live birth, it was the presence of homogeneity of the testes. So a parameter that comes from ultrasound. You can see the odds ratio is even higher than total sperm count. On the other side, you can see other parameters, but for example, microlithiasis and also varicocele were not predictive. And if we were evaluating varicocele prevalence in our population comparing fertile and infertile men, you can see that considering all grades or even severe varicocele, so grades 4 or 5 at ultrasound, there was no significant difference. So varicocele probably has a scanty effect on fertility. And then we have other information. Among epididymis characteristics, the presence of normoechogenicity of the head of the epididymis was a good predictor. Considering prostate, the most important were the absence of hyperemia of the prostate, that means no signs of inflammation of prostate at ultrasound. The presence of, so when there were midline prostatic cysts, they had to be very small, and the absence of dilatation of ejaculatory duct that usually suggests distal obstruction. And considering seminal vesicles before and after ejaculation, we could evaluate the delta of the seminal vesicle volume, that is a good predictor, and also the seminal vesicle ejection fraction above this number, 38%, that is the contribution of the seminal vesicle to the semen volume. So it means that when everything is going well, I mean good testis homogeneity, good contraction of the seminal vesicles, good epididymis, this is predicting better the pregnancy with live birth. But if you see here, if we have a multivariate analysis for the risk of pregnancy with live birth, introducing male and female age, sperm total count, or sperm concentration, progressive motility, FSH, ultrasound testis volume, testis homogeneity, you can see that the testis homogeneity was the one that had that was the best predictor of a pregnancy with a live birth, especially with a higher XDB, and it was followed by sperm progressive motility, sperm count, and ultrasound mean testis volume. So going to the conclusion, after considering anyway, so after all the consideration I made about overlapping on 7 parameters and the fact that it's not easy to find predictors, I can tell you that this study reports comprehensively some thresholds predicting pregnancy of live birth, and it can be used in clinical practice to evaluate the potential of the male partner presenting for the first time in an outpatient clinic to induce a clinical pregnancy with live birth. It means this is not the Bible or the Quran, but it means that it can help you when you have the couple for the first time in your office to evaluate the parameters of the male partner and according to this cutoff say if there is a higher probability of fertility potential for that man. Testis homogeneity, mean testis volume, normal epididymis at ultrasound, and sperm concentration above 40 millions, and sperm total count and progressive motility are the best predictors. But the final message is also testis ultrasound should be done in all outpatient clinics to evaluate this new parameter to be considered as very important as predictor of male fertility, that is the homogeneity of the testis. So after that, I thank you for your attention. I invite you to follow up and write me if you would like to attend the ultrasound school of the European Academy of Andrology that I am coordinating with a colleague in Rome, Professor Isidori, and I would like to invite all of you to the ESHRE SIG Andrology Campus Workshop that will be held in Florence in October 30-31, 2026, so this year, about the evidence-based management of complex causes of male infertility. So thank you very much.
Thank you very much, Francesco. This lecture is open for discussion. We have a question, gentleman over. Okay, please. Please.
Hello, thank you for the lovely presentation. I'm Zora, I'm from Manchester. My only question was, how did you signify the inter-observer variability? Because ultrasound can be a very subjective assessment. And what one person will consider homogeneous, not necessarily the other person. What was the percentage of homogeneity in the testicular ultrasound?
So this is a good question. And I invite you to 2 days ago, because we had the pre-congress course about male infertility, and we showed this data. Anyway, I'm joking. Obviously, I can tell you that we have very highly standardized methods you can find in the study of the EAA. So to be honest and to tell you, the 11 centers that participated to the study, they had 3 investigative meetings before starting the study in order to have the lower inter and intra-operator variability according to NATA, NATA, and if you read the paper, you will see the report of this variability that was really very low and acceptable for to have reliable statistical analysis.
Yeah.
And we also published in the methodology how we evaluated the parameters. So if you check them regarding the continuous parameters, obviously we have a continuous scale. If you think about homogeneity, for example, you can check on that papers, and we had a 4-scale degree, a 4-scale Likert scale with 4 degrees. And it is reported with pictures and with analysis how we could define homogeneity or inhomogeneity. And all the people working on this, they use the same way to evaluate the male.
So different people who were assessing the images had looked at the images anonymously and figured out what stage would they consider, as if a certain image of a testis, what would one person consider as homogeneous, and was that cross-tested with another person? Would the next person also consider that as homogeneous or not?
Yes, I understand. But anyway, what I can tell you is that, so it could be even maybe more difficult to define if you have a grade 1, 2, or 3 of inhomogeneity, so according to severity. You have to be, a good sonographist, but if you see the pictures, you can find the difference. It is like thin hypoechoic striae, thick hypoechoic striae, or geographical map appearance of the testis. But I think it's very easy, even for andrologists, urologists, gynecologists, to see if a testis is homogeneous at ultrasound or it has inhomogeneity. Then it is not required in this study. We have another study that is going to be published to check the severity according to the classification of the testis inhomogeneity, but just to see if that testis is homogeneous or not.
Thank you.
We have the second question, gentleman on my left.
Yeah, Gulam Bahadur, UK. This way. Hello.
Yep.
This way.
Okay.
Okay.
Francesco.
So,
Okay, myself, I want to ask a question about.
Excuse me. First question here, this gentleman here.
Okay.
hi.
Yes.
Yep.
So, we need a lot more sperm to achieve a pregnancy. On our IUI program, we've had most of our pregnancies with over 20 million motile progressive sperm, and I noticed the same thing is with ESHRE, where there are more than 20 million motile sperm, they seem to achieve a much better success rate. I wonder if you could comment on that?
But this was nature of the
So the comment is that you can see the studies that have been published. Here we are trying to check what could be the predictive parameters for natural pregnancy, especially considering fertile couples. And as you saw, the fertile couples group had no relevant gynecological problems for the female partner. So it means that we try to check which were the cutoff predicting more. And I agree with you, and also we agree with previous publications on high-level journals. So I showed you New England Journal of Medicine, regarding the fact that the induction of a pregnancy has a higher probability when you have, for example, sperm concentration above 40 millions per milliliter. It doesn't mean that if you have 20, you have not. You have seen all the other studies. But if you want to give a prediction to the couple, considering just the male, because, you know, as andrologists, we usually see only the male. Sometimes the gynecologists, they say they see only the female. Sometimes we see the couple. If you just check the information about the male, this could be parameters. And I agree with you that for natural fertility, usually the male should be health. And health means that should have higher levels of concentration, motility, morphology, and good male genital tract.
So
That's quite obvious, but not so much.
So thank you very much. I'm sorry we are running out of time, so we need to move to the second lecture. So thank you very much, Francesco. Thank you for everyone.
Thank you very much.
So next speaker is Dr. Joris Velman, and he will talk about the genomics in reproductive health, diagnosing male infertility and predicting the success of medical-assisted reproduction. Professor Velman is a Dutch human geneticist, chair of reproductive genomics and director of the Institute of Genetics and Cancer at the University of Edinburgh. Prior to this, he was director of the Institute of Genetic Medicine and dean of the Biosciences Institute at Newcastle University. Before that, he worked at the Department of Human Genetics, Radboud University, and in the Netherlands. He contributed to unraveling the genetic causes of rare diseases to our understanding of mutational mechanisms underlying genetic disorders and the implementation of genomics approaches in medicine. His research provided with strong experimental evidence for the novel paradigm in severe early onset disorders, and in 2016, Professor Velman and Brunner were awarded the King Faisal International Prize for Medicine for pioneering the clinical application of next generation genetics. Since 2021, his fellow of the Academy of Medical Sciences in United Kingdom. So, Dr. Bellman, the floor is yours.
Thank you so much, and thanks for the kind introduction. It's great to see so many people here to hear about genomics in infertility. It's not a topic that you work on perhaps every day, but it's great to see so many of you have an interest in this. So I have no commercial or financial interest, but I would like to tell you that I'm CEO and founder of Fertility Research UK, a non-profit charity, which we are soft launching here at ESHRE, which really aims at supporting research in the field of fertility and reproductive health. So just as a kind of an advertisement. So because not everyone will be a geneticist in this audience, I will start a little bit by talking to you about genomics, because a whole lot has happened in the field that I work in the last decade or so. So basically, up to, let's say 10, 15 years ago, we were looking at individual genes using Sanger sequencing, and we could look at variation in genes, but we had to pick them in order to analyze them. That has all changed once we started to use next generation sequencing, which allows us to look at the entire genome now in a matter of hours and for less than 100 pounds. So this is dramatically changing our field because it allows us to use genomics in medicine routinely. And that is really what's happening. So clearly, the advantage of this is that you can actually do a single test, and single tests make things easy. So you basically draw some blood from a patient, isolate the DNA, put it in a machine, and you get the entire genome, which means 3 billion nucleotides in your computer, and you can start looking at that. That is now the easy part. The difficult part is the interpretation, and at this conference there's quite a few presentations talking about variation in the genome and how it can be related to fertility, and I think that's one of the points we have to work on jointly. But what you see, if you look at other diseases, and that's, I think, important to always do that when you work in a certain field, you see actually that genomics is nowadays used routinely in rare disease and in cancer. So, for example, the UK was pioneering that in England with Genomics England, sequencing 100,000 genomes just a few years ago. And now routine genome sequencing is used to basically determine what's the best treatment for patients with cancer, but also to advise patients with rare disease. So this is no longer something strange and weird and something for research. No, this is used in medicine, and it's changing really the lives of patients. So the question then, of course, is how does it work in our field? So before we start with that, I just want to basically talk about things that we know and that we don't know in our field. And many of these things will be very familiar to you. So 1 in every 32 children in the UK is now born through IVF, so 1 child in every classroom. But only 1 in 3 women gets pregnant per embryo transfer, and only 1 in 4 gives birth per embryo transfer. In one study from the UK, 156,000 women underwent 257,000 IVF cycles, and 70,000 children were born. But actually, the message that is not often coming out there is that 86,000 children remained childless after multiple rounds of IVF. And what's the question, of course, for us here in the audience is who will be successful with IVF and who will not? Because what's happening nowadays, we're just pushing them all through. And it's just not working in the majority. So we're not doing good personalized medicine, we're not doing good care. In addition, if you look at infertile men, they actually are at risk of other diseases. They are at higher risk of testicular and prostate cancer, higher risk of diabetes, multiple sclerosis, and have a higher mortality rate. Wouldn't it be wonderful if we could actually identify those at higher risk and actually take them and take care of them, right? We shouldn't just focus on the testes. We should look at the entire person. Now, another thing is that when you do medically assisted reproduction, you bypass normal selection. And we're already at the opening session of this conference, we heard about how this is changing evolution of our species. And one of the things that you would wonder about as a fertility doctor is, well, if you're treating an infertile man and perhaps this man gets pregnant of a boy, the partner gets pregnant of the boy, what's the chance of this boy being infertile? Wouldn't that be wonderful if we could know something about that so we could take care of that? So for most of these things, you have to turn to genetics. Now, I work very proudly, since last year in Edinburgh, at the University of Edinburgh, in the Institute of Genetics and Cancer. And I only recently found out that in that institute, Patricia Jacobs, here pictured, discovered the cause of Klinefelter syndrome in 1959, XXY. So it's really, I'm standing on the shoulders of giants. Unfortunately, Patricia passed away this year. But we have looked at Klinefelter syndrome for a long time. So this is a subtype of infertility that we can now define because we look at the chromosomes. And what we now know from all these years of research on Klinefelter syndrome, that spermatozoa can be found in about 50% of patients. ART live birth rate is about 16%. There's a risk of osteoporosis. And there's also an impact of aging on sperm production. So basically, when you've done a genetic test, you've identified Klinefelter, you can give some specific information to patients that's relevant. But this is only a subgroup of our cohort of infertile men. So if you look at the genetics, you would look at chromosomes and identify Klinefelter syndrome. You can look at the Y chromosome microdeletions, very well known, identify another few percent. But actually, most of the mutations in the DNA that cause disease, they are monogenic. It means individual mutations in genes. So you need to look at an entire genome. You need to sequence that because infertility is genetically heterogeneous. And if you do that, then you can get a high diagnostic yield. But unfortunately, this last part, this monogenic part, is largely underexplored. And as a consequence, when you look at where we are now, in 2026, where patients with rare disease get genome sequenced, where patients with cancer get genome sequenced, what's happening in our field? Patients still get a karyotype. Patients get a screen, perhaps for the CFTR gene. And the Y microchromosomes, the Y chromosome is studied. But basically, large part of the genome, 90%, is completely ignored. So that's where we have to do something about. So when I moved into this field a number of years ago with one of my first PhD students, we looked at literature which had described genetic causes of infertility. And we associated this literature, we evaluated the link between the genes reported and infertility. And what we found was that, unfortunately, the large majority of literature is not describing genetic causes very well in our field. And for the large majority, we could not even evaluate whether the genes reported could be associated with male infertility, or basically there was no strong evidence at all. So this means our field is not publishing science in the good way. And only 48 genes were published out of more than 600 that we could really now say mutations in these genes are reliably associated with male infertility. So that's a very small number. And we think there may be up to 1,000 genes that when one of these is mutated can cause male infertility. So we have a long way to go. So for specific forms, and I'll come back to that in a moment, for specific forms of infertility, there are more genes known. But if you look, for example, at non-obstructive azoospermia, which is the big group of infertility that we see, there's only 14 genes now associated with them. So there is a lot of work to be done. So what we did a number of years ago, we founded the International Male Infertility Genomics Consortium with a number of colleagues, and the idea is to really work together because you can't solve this on your own in the laboratory. You need large patient cohorts, you need to replicate your data, all of these things that are critical in science to advance the field. And with our colleagues from around the world, we've now identified a number of genes and reliably associated these with infertility. But also published papers where we actually said, well, this gene was published by one group as an infertility gene. We actually have very clear evidence that it's not causing infertility if mutated. One of the the two biggest publications are the ones on the bottom, where we've looked at large cohorts of azoospermic men, where we've done exome and genome sequencing and identified many new genes that are at this level still at the level of candidate genes, but hopefully can become causal genes that can be added to diagnostic panels. So there is a lot to be done, but there is progress being made. And I now want to go into some more detail of individual phenotypes to show where genetics can be useful. And one of the important things in our field, again, is that when we do genome sequencing, we report on variants. We actually report these variants completely the same throughout the world because we have a very good nomenclature. However, clinicians, when they describe the same patient, they often use different phenotypes. So one of the things that is used again around the world for different diseases is a so-called human phenotype ontology. So that's a systematic way of describing phenotypes, which really is essential if you want to share data with each other around the world. And this is something that we've proposed in a recent review. And basically, this is critical if you want to find genes and associate them to specific subtypes of infertility. So let's now look into some specific sperm defects. So if you look at qualitative sperm defects, which are relatively rare, we actually see that genetics is providing very high diagnostic yields in these phenotypes. So if you think about globosospermia, macrosospermia, or MMAF, multiple morphological abnormality of the flagella, genetics can actually diagnose the large cohorts of these patients with a small number of genes. So this is something, if you see these in your clinic, genetics can really be used to confirm what the diagnosis is. If you then look at more quantitative sperm defects, there are various types of these, and one of them is meiotic arrest and round spermatid arrest. And again here, it's a high diagnostic yield if you look specifically at these histological types of infertility. And you see that, for example, for meiotic arrest, there's now quite a large number of genes that we can diagnostically test. So again, we are moving towards an area where we can predict this. However, it's not the case that for every gene, mutations in the same gene will cause the same phenotype. So there is also phenotypic heterogeneity, which is always the case, unfortunately, in our field, and that means we need to further do research on that. Interestingly, when you look at genes that cause meiotic arrest in men, actually, because, of course, meiosis is very similar in females, you also see that these genes can also result in premature ovarian insufficiency. So this is, again, important when we think about this in families, when we see these mutations. This is not only for men, but it's also for women important to consider. And this is, again, telling us important information that's biologically relevant. Now, with this information, what's starting to happen in various countries is that clinical sequencing is being implemented. Exome sequencing or genome sequencing is now coming to a stage because it's really affordable. It costs you 100 or 200 pounds to do this nowadays. So you can start doing in different clinics this. So this has been now pioneered by a number of laboratories. And what you see here is a few publications that just reporting on the first results. So the first publications looked at a relatively small cohort of 96 men with unexplained NOA and identified a likely cause in 16 genes in 23% of patients. Larger cohorts, and this is often what you see, if you look at bigger cohorts, you actually see that the diagnostic yield is a little bit lower. So a group from Germany published a diagnostic yield of 8%, and a group from, let's say, an international consortium came up to a diagnostic yield of 12%. So that is in addition to the Klinefelter, in addition to the Y chromosome microdeletions. So that's important. And what's also important is that basically from all of this work, we're finding more and more genes that can be used diagnostically in diagnosing these. Clearly, what is important is that research and diagnostics goes hand in hand, because if you look at all genes and you make a diagnosis in 10 or 12% of cases, there's 86 or 88% of patients where we have not found it. But our researchers can find new genes, publish these, and in that way increase the diagnostic yield, as is done in other fields. So it's very important that we try to implement these tests into diagnostics when this is possible, but of course it depends on your healthcare system. Now this is perhaps the most important slide if you think about the relevance of genetics in fertility clinics. This is actually, can we, when we have an infertile couple in front of us, can we already predict whether teaser will be successful or not? We just heard a presentation about all the challenges that there are, and actually genetics sometimes can be very black and white. So if you have a subtype, a genetic subtype, it can actually help you to really say, don't do teaser here, it will not work. Because we've already identified 12 patients with mutations in these genes, and for none of them, the teaser has worked. So this is about preventative care, actually about reducing the number of tests and the number of medical things you do in your patients' groups, and I think it's important. So this is something to look at, and a good publication came out recently. Clearly, again, this will not always be black and white. For certain genes, there will be some patients for which it works, for others for which it don't work, and we need to further study this. This is how research goes. Now, one of the things that we've looked in this field for a long time at is we've looked at recessive forms of infertility, at X-linked forms of infertility. But one of the things we have not looked at is dominant causes of infertility. And if you think about Klinefelter syndrome, if you think about microdeletions on the Y chromosome, they are actually occurring new in your genome of your patient. They were not present in the parents. And this is something that we've seen in other diseases coming out as well. So new mutations coming into the germline of a patient, and they arise during spermatogenesis or oogenesis, and they are an important cause of disease. So this is something that I've worked on for a long time, initially in rare syndromes and intellectual disability, but now I study the role of these mutations in infertility. And one of the things, so in order to identify these, one of the challenges you have, you cannot just sequence the genome of a patient, but you also have to sequence the genome of his parents. So this means we need patient-parent trio sequencing. And of course, that is more difficult to do in infertile men than in children with intellectual disability. Because children with intellectual disability, you know, basically the parents come to the clinic, bring their child, and the doctor can take blood from the patient as well as the parents. Unfortunately, the infertile man does not come to the clinic with his parents. It would be so much better for research, but that's where we are. But we can ask him to participate and then contact the parents, and in this way we have now collected a small cohort of trios for doing these genetic studies. So in 2022 we published the first study on this using exome sequencing in 186 patient-parent trios, and we've now expanded this and we've replaced this by genome sequencing, and we've done this in more than 300 trios, working with colleagues from around the globe. So that is showing us that these de novo mutations, they are really important and they can explain the dominant causes of disease. And realize that if you have a dominant infertility, it would mean that if you would pass on this infertility through ART, actually you have a 50% chance of passing it on to your children, right? Whereas with recessive disease, you will not pass it on, you will just have a carrier as a child. So it's really important to know the genetic inheritance model. So one of the things we found recently is that we found in this cohort of more than 300 trios, we found lots of mutations in different genes. And again, this is fabulous for scientists, but challenging to interpret. We found now a number of recurrently mutated genes, so they are good targets of further study. But of course, for the rest, we're still working on this. So one of the things we found is that you can use AI tools, all kind of variant interpretation tools, and many of these mutations can be classified as likely pathogenic. That doesn't mean they immediately cause disease, but they are interesting to look at. And when we look at these mutations that are predicted to be pathogenic, one of the things we noticed is that they are actually showing an enrichment in specific pathways. And these pathways have to do with mRNA splicing and polyadenylation. So these pathways, mRNA splicing, is very important in spermatogenesis, and it's the first time that we now see these mutated in these dominant forms of infertility. We do not see this when we look at the recessive or X-linked forms. So that's something we're further studying, but what we noticed already that in just our cohort, the spliceosome, which is the mRNA splicing machinery, is mutated in 5% of our patients, and that really indicates that this is a very important pathway to further study. Interestingly, we're not just looking at these new mutations, but we're also looking at mutations that are inherited from the mother, because you could imagine that you have mutations that do not give rise in female infertility, so can be passed on through the mother to their son and then result in male infertility. So that's something we're looking at, and it's another form of inheritance that you can only study when you have these kind of patient-parent trios. So I'll stop here, and the conclusions are that genomic medicine is here to stay. It is being used routinely for rare disease and cancer and really helping to treat patients better. It is providing a high diagnostic yield for various subtypes of male infertility, so it can already be used now. And it is providing important information about the success of TISE. And I think by doing this at larger scale and for a longer time, doing this around the world and sharing information, we can learn so much really important information that we can pass on to our clinicians and to our patients. It tells us whether there's a risk of passing on your infertility to your offspring, and that's important to know. And of course, it's also pointing us to new biological pathways that offer future therapeutic options. So we really have to try to move now from a research setting to a diagnostic setting, which is happening in certain countries, and I'd love to work with you all to do this also in your country. So I want to stop here, thank many of the colleagues that have been critical to this work, my colleagues from around the world, and finally leave you with this advertisement for Fertility Research UK. Thank you so much.
Thank you so much for this wonderful presentation. Now it's time for questions. I think we have one on the left side,
Okay,
please.
okay, thank you. From your perfect presentation, I heard that you said that there is now genetic parameter that help to test, to predict test success. This is very wonderful. But I would like to know if there is either emerging genetic or epigenetic parameter that we can use now in the laboratory to predict successive pregnancy from semen analysis. If there or not yet, we have to continue research on it. This will make life better, especially for donor semen sample.
Thank you so much for your question. I may not completely understand it, but so basically what we can do for a subgroup of our patients where we see specific mutations in certain genes, we can predict whether these will be successful in getting pregnancy. You want to know whether it results in live birth? Is that what I'm talking about here?
No, I would like to know if in the semen samples,
yes,
we can take the semen fluid and measure either genetic or epigenetic parameter that's currently emerging based on research available in current situation. If is there any parameters that we can test in the semen fluid to detect or to predict the successive pregnancy, or not yet available? We have to continue on the just morphology, county, and the motility, only that.
Yeah, so what we do is we basically don't look at the sperm or ejaculate or fluids. We just take blood from a patient and look at the germline DNA, and that can predict whether a man, basically what's the causes of his or her fertility. But we don't use it as a biomarker, which is more what you're looking at. So, okay. So no, I don't know too much about that. Sorry.
Okay, thank you.
Hello, I'm Dr. Sujay Dasgupta from India. Hello. First of all, thank you for elaborative lecture. My question is, if we find any genetic problem, in that case, in the father who is harboring some genetic mutation, in that case, can we offer PGT of these genes, like these novel genes? In that case, should we do PGTM to avoid transmission of infertility, or rather, is it ethical in that case? Because we're just discarding the embryo just because it's at risk of having infertility when it will become adult. Is it ethical? Should we offer PGT in that case?
So I think that what we are seeing is that, of course, in these men, you basically, because of the genetics, you know that they will have challenges in becoming pregnant, right? You're asking if they then would result, for example, in an embryo, should we do then PGT?
Yeah.
Yeah, that is a potential opportunity in the future. Yeah.
Thank you.
Please.
Thanks, Joris. We have been working for many years, and I'm amazing all time you talk. What I wonder, how many times you have to find the same mutation to make sure that your gene is describing infertility, because you presented the picture of Ria Escamilla, and having a cohort that many times are described in literature, but we found sperm in those genes. So not every mutation is the same, whatever you said, every variation may be different, but how many patients we need to confirm this is really infertility gene?
It's a great question, Liliana. I think it's not that black and white. There's different levels of evidence that you can have. So one is indeed multiple patients with a mutation in the same gene. It doesn't need to be the same mutation. Another can be more functional evidence. So there's different parameters that play. Do all the patients have the same phenotype? Helps. So it's not one aspect, but in general you could say, also for example, it's important that studies are being replicated, so not the first publication, but then the second publication. So all of these things are important. So clearly, if somebody reports this for a first time and says this is a new gene for infertility, that's great, but that's a candidate gene. You always need replication. So I think in that way, yes, we're always a bit more conservative. And we have to be careful by saying this is now a diagnostically relevant gene. But in general, replication and then some functional validation would be really critical to make this a diagnostically relevant gene. Thank you.
Can I have one?
Yeah, please.
So if I may,
Yes, of course.
this is absolutely amazing, but I think about non-obstructive azoospermic patients in the clinic now that we are expanding the genetic testing.
Yes.
So yeah, apart from the Y chromosome microdeletions, what kind of, variants or pathogenic variants you consider more powerful for us to counsel our patients apart from, the conventional analysis, which actually genes we should perhaps include in our routine infertility panel, or we are not there yet?
Yeah, no, so I think this is where I referred to this publication from the colleagues from Münster, from Stellmeyer et al., who published basically a gene set of about 38 genes that for NOAH you would use in addition in your diagnostic setting. Now the type of mutations, that's a bit different. So you have missense mutations, stop mutations, and it depends a little bit on each gene. So again, this is where geneticists need to be involved in doing this evaluation, because this is not something everybody would just routinely do. You need to be trained for that. But for some genes, it could be a combination of mutations. Sometimes you have one specific mutation that causes disease. So there's not one answer to this.
And it's a very complex topic, because you know that the sequencing provides you with a lot of information. So I agree with you that probably the most difficult part is on interpreting. It's very difficult also to put all male infertility cases in the same box, because to me, probably the non-obstructive azoospermia is the most clear situation. When we deal with varying sperm quality samples, this to me it's very difficult to link with static genomic information, which is you have these genes and you have a varying amount of spermatozoa, so probably this is not only explained by the genes contribution. But I think the most practical, the clinically practical use is on predicting the test success, because if possible, then you avoid unnecessary biopsies.
Yep.
And then my question comes to the 2025 paper you mentioned, how the predictive ability of this combination of genes perform in comparison with classical FSH, testicular size, and imaging even to predict the success. Do you have information on this paper about that?
No, that would be going too far. So I think clearly you need to use it in the combination with the other clinical parameters you have. But the nice thing with genetics is it can be very black and white, as you've seen for a number of these cases. And again, I think this is something we'll see more and more. And it may sound all very difficult, but just to remind you again, in the UK, every patient with rare disease gets their genome sequenced. Every patient with cancer, they get their genome sequenced. This is not something, it is difficult, but people, geneticists, do this in a diagnostic setting, and they learn to deal with it. If we would implement this, for example, here in the UK, in the NHS, and we would do this routinely, we build up the evidence. The difficulty, of course, if you have your first patient with a mutation, that's difficult. But when you've seen 10, it gets easier, and this with all of these things. Right? So I think it's really important that this, and this is not just in the UK, this really needs to happen around the world, and we need to share our data, that's critical. And again, by doing that, and then you see some variation, you say, hey, for this gene we see some patients with T's as success and others not. Okay, let's look further at the genome, other things.
So more information is needed, yeah.
But I also agree with you, there is other parameters where, for example, methylation and all kind of other things play a role. So genetics is not the answer to everything, but it does do a lot of things already.
I agree.
Thank you.
Is there any other question in the audience? I think it's only 30 seconds left, so we can just thank our both speakers.